It's nice to wake you all up at 6:30 in the morning. You know, when one walks into this hotel, you see right away how big the world is, because this is a pretty darn big hotel, and it's amazing. I've been walking around this morning talking to a number of other researchers and folks in the world of kind of lysosomal disorders. And Elsa, I understand that you're the keynote speaker here, and you were telling me how in the 1990s this all sort of began in a pretty small way, and I was sort of reflecting that in the 1990s, how big would this conference have been?
Maybe 10 people.
Maybe 10 people. And so we're blasting it out this morning just with those folks of you that are here. This morning our job is we're going to do 2 back-to-back panels. The first right now is called Looking for a Cure, the Rare Disease Patient Experience in Lysosomal Storage Disease. And we're going to have a chat here. And then we're going to have another just immediately after a panel, a really, really cool panel. Let me just give you the title here, is When There's No Diagnosis and One Rare Disease Researchers Hunt for Answers. And I want to mention this because in the audience we have Sean Papworth over here, and I'm really falling in love with Sean. Sean, wave to everybody. Let them know you're up there. Sean is someone that has a rare disease here, but we were just talking about a Tom and Jerry movie and how much he loved that. This is not going to be a Tom and Jerry movie, but there's no reason why we can't have a little fun. Let me start with you, Elsa, just in this, as we talk about this, and particularly with Cara's work and experience in the Sanfilippo rare disease element of this, and we want to talk about the Sanfilippo Foundation. What do you think, from a journalistic perspective, folks in my profession need to understand more about what is evolving among the stakeholders? What is the thing you most want to tell people right now listening in on video and in the audience that you think we're not getting?
Well, I think there are maybe 2 things. One has to do with the importance of early diagnosis. I think that the field is getting better at it, but we're really not there. Mm-hmm. And one of the issues in trying to provide a treatment for children is that earlier treatment is more effective. I think that's a very important fact, and it's something that is being addressed by newborn screening, but we also need to educate pediatricians mm-hmm. and general practitioners and just get the rare disease area on their radar screen. I think this is one.
On a scale of 1 to 10, when it comes to literacy on those issues in the field, where would you put the literacy and awareness on the rare disease phenomenon?
Oh, maybe 4.
4. 4 is pretty good, though.
You know, it's very variable, and it depends where people
We ought to rate, kind of go across the room and ask what they think. But
yeah.
But let me jump over to Cara. Cara, you've been living this. Your daughter Eliza, you thought was a baby with normal, grew up to be 3, had begun to speak, had begun issues, and I'd love to hear just a little bit about your journey into this unexpected fear. And I should note that you're a doctor.
Yeah, I worked in special needs,
right.
Kind of ironically,
mm-hmm.
for many years. And when we did get the diagnosis for Eliza, speaking of literacy of rare diseases,
right.
They told me what the diagnosis was, and I remembered the category. I remembered, hunters or hurlers, the ones that they show you the pictures of in the book, and it's a question on your medical board exam. And so I knew enough to know that it was horrific mm-hmm. what we were facing. But
and she was diagnosed specifically with the Sanfilippo syndrome?
She was. We went through a series of testing as she started to kind of veer from her peers in her development around age 3. At that time we were told she didn't meet criteria for therapies. Mm-hmm. She was still okay. Come back in 6 months if it's not better. Clearly, it was not better. At that time, she was diagnosed with autism, which is pretty common. And these children, they have the behavioral aspects early, along with a lot of ear and sinus stuff.
Mm-hmm.
So everything in hindsight, we're like, yep, I can look back at those baby pictures now, mm-hmm. and I can see it. Right? So would we have liked to have been diagnosed earlier? Absolutely. There's so many times I go back and think, hindsight's 20/20 though.
Right.
You know?
Right.
So you and your husband, as I understand it, went out and you really tried to say we need to become stakeholders. You went out in the community and raised, as I understand, about $3.5 million, if I have the numbers right,
Yeah.
and you've begun a foundation.
Yes, we have.
But again, I'd ask you the same thing I asked Elsa. When you sort of look at this journey you've been on, and so much of it does focus on cures, at least in the field as I see it, and the discussions I've had it, both diagnosis and then cure. As I understand it, you're trying to look at more about the journey.
Well, we all want a cure. That's the golden egg. Of course, that's important. But it doesn't mean that this patient's life and their quality of life is not important. And I think that's largely being overlooked in the development of treatments and cures, is looking at how can we address the extreme amount of pain and suffering that these children go through. And that just because you may not be able to rescue cognitive or intellectual ability doesn't mean that that child's life isn't worthwhile, meaningful. So I think there's a lot of ethical and kind of the paternalistic aspect of medicine kind of underlying a lot in drug development.
What is your experience? Share with Elsa. Go ahead.
Yeah, I just wanted to make a statement about my experience in a long time ago. We were talking about that in Hurler syndrome, which is another one of the mucopolysaccharidoses, which Sanfilippo is one of them. Hurler syndrome is easier to diagnose because there are a lot of physical stigmata, and you can see the disease. And back in the 1990s, I worked with Dr. William Crivet, and we did the first bone marrow transplantation for that disease. And since then, that has become the standard of care for those children. And one of the things I want to emphasize is that it is not a cure for those children. What it did was to prevent them from dying at the age of 5 to 10 years old. But these children now live until their 20s. I mean, we know that there are many children that are in their 20s, but they still have a lot of problems. They still have orthopedic problems. It is not a cure. And I think we really need to adjust our expectations for the initial stages of drug development to make sure that we aren't just going for a cure. We're going for, things that are going to improve the quality of life of the children. These children now, they function fairly well, and they function in schools. They may need special ed, but I know of a boy who is in his late 20s who drives a truck and is doing quite well in his rural environment. And, that to me is a success. It doesn't need to be, a cure in the sense of getting rid of all the symptoms.
I'm interested in when I think of the Atlantic and great journalism out there, they're essentially storytellers. And what I've been interested in your story and other stories I've read about here, and I assume everyone in this conference has a, do you have platforms within the lysosomal world, if you will, for storytelling of this sort? Because when you just talked about that there are some people become 20 years old and whatnot,
Right.
it means you're aware of them and you're in the
Sure.
center of this. But I also know that there haven't been registries, that there have been concerns about the failure to share information about the inadequacies of markers to compare cases. So I'm just sort of interested in both real storytelling but also scientific storytelling and what you think needs to be improved.
Well, our disease group, the MPS diseases and Sanfilippo in particular, has addressed the issue of a registry, and now we
Right.
are.
You
we
do have a registry now.
up and going, and we are building that to be more robust over time. As far as telling the real meat of patient stories,
Right.
We as a foundation do a lot in social media because we know that is what touches people. We know that that's what, we're humans. We
Right.
engage with other humans. When we got the diagnosis for my daughter, my husband and I went out to the car, put her in the car, and just sat there and cried. What are we going to do? Our entire world was just brought to rubble. Not for 1 second did we think, okay, I guess we're just going to see what happens and watch her die, though. No. The answer, I'm sorry, there's nothing we can do for you, was not going to be okay with us.
Right.
So, we have watched this disease in our daughter. We've watched her gain a lot of skills and lose a lot of skills. And it's heartbreaking.
And you have also been out there and said that cognitive endpoints are perhaps the wrong goal.
I wouldn't say they're the wrong goal. I would say that I think it feels that we are stuck on that is really the only goal. And I would say that there can be a lot of other very, very meaningful goals that can do a lot of good for children who are suffering. And I think that will only kind of come to be when patient advocacy groups and patients are incorporated in this drug development process from inception of the idea that I want to work on this disease, clear through clinical trial design and marketing application. I mean, I think it needs to be an integrated approach with patient advocates at the table every step of the way.
Elsa, your thoughts on that? I know that you are an advocate of greater clarity and cognitive endpoints.
But they're not the only thing. They may be what the FDA likes or what the researcher needs to quantify an outcome. But there are other things that are also important. Behavior.
Right.
I mean, the quality of life of patients with Sanfilippo syndrome is impacted hugely by behavioral abnormalities that disrupt the family, system. Sleep problems in these children are a big, big issue. They contribute to the behavioral problem, and they're a big problem. There are, just the skills of daily living, that need to be addressed. So all of these things need to be incorporated together in understanding whether a treatment might be effective or not. And so the pharmaceutical company needs to, not only address the cognitive endpoints, which they might use as their primary endpoint, but they also should be looking at behavior. They should be looking at adaptive skills, the daily living skills, all kinds of things that affect the whole ecosystem of the patient.
Now Pfizer's here today, and Togo's doing this, Pfizer's doing this, but when this, you both made this comment that pharmaceutical companies need to do X, are they not doing X now in your impression? Is there sort of a lack of performance? Is there a critique that I'm hearing?
And I don't think it's just pharmaceutical companies.
Right.
I think it's scientists, academia, it's everybody.
Sure. And I think one of the problems is that we don't always know how to go about measuring these things.
Right.
Okay? So in your measuring a treatment effect, you really need to know how to measure the behavior. You need to know how to measure the quality of life of a family, and our tools are not good. You can't use off-the-shelf type of measures to indicate whether or not a person has a good quality of life or not. You need to develop disease-specific measures, and I think that it's been a sore lack in not only the pharmaceutical companies, but also in academia. And I think that there's a real need, we've been talking about this, to have the patients, the parents, the pharmaceutical companies and the scientists work together to develop some of these measures, find out what the parents want and what they think is important, and then incorporate that into what you're going to develop to measure whether a specific treatment is going to work or not.
So what do you think? I mean, you're a real pro in this, and I guess when I hear these things that different groups need to do something differently and to have new habits, I guess I always find myself skeptical of someone who's worked in big organizations that those things happen unless there's a good model to follow, or you've got someone really to kind of whip the system into shape so that you can demonstrate that. Is your experience that there's anything out there that the different stakeholders in this can say, hey, here's what we did in some part of this world here, or not? You have to kind of invent it along the way.
Can I just say something about the Lysosomal Disease Network,
Sure.
which is what this whole meeting is about?
Right.
In that effort, patient advocacy is required by the NIH grant that originally funded this. And so maybe it's been underdone. I mean, maybe there needs to be more parent input. I think there does. But
it's built into the DNA of this.
Yeah, and I think, I mean, there are parents here. They come to this scientific meeting, and they ask questions and they participate.
Right.
And I think that's really the first step. A real collaborative research project, I'm not sure I've actually seen that in
maybe next year.
Maybe next year. But the consensus conference, for example, which you mentioned, was a real example of that, where we worked with the MPS societies of the UK and the US. They organized it, and the pharma companies who were told they can't participate, they can observe, but they supported it. And they supported it very nicely. So it was and we invited 125 scientists to come to this. And so it was a great sort of example of that kind of collaboration. That could happen at every single disease. This was only on MPS diseases. So it could happen, for every rare disease that needs some consensus about how to go about measuring outcomes. You were there.
It was fabulous. It was really groundbreaking, I think, for us moving forward as an MPS community. But I think, pharma and academia, or anybody outside the patient group, I think has to have a willingness to kind of, open the curtain a little.
Right.
And,
So who needs to open the curtain?
I think, pharmaceutical companies and academics.
Right.
And willing to recognize that the patient perspective, maybe they don't have all of the scientific words that you use every day.
Right.
But we have a lot of really smart, really educated, really involved patients in the rare disease community that can add an incredible amount of insight into meeting everyone's goal. Helping the patient, getting you a marketable drug, getting you publications, everyone can win.
I want to go to the audience in a minute and kind of do a quick lightning round, because I'm so interested in this issue about information sharing. In the non-rare disease area, say cancers and others that I've chatted with folks about, there are debates about things like HIPAA and the whole business of science in the sense that the business and innovative side don't want to share some of their research with others. And I'm just sort of interested to what degree HIPAA is an issue at all in uses. So it's not. You've said, okay, we can skip that. But I mean,
so.
it is, I can tell you,
I mean, do you
there are
think it
raging
is?
debates in Cambridge, Massachusetts over this right now.
I think families have less, from the family side, I think, treatment is the primary goal, and the patient's risk tolerance, including sharing of personal information, is very, very high.
Yeah.
And I think the other question I have is, you both talked about, I know Eliza has undergone gene therapy recently, and I understand you're going to get results this week, I've been told, but the whole genetic dimensions to everything, the advances that are being made there. I interviewed Ann Wojcicki last year of 23andMe, and of course there are the big campaigns for people to go get their genome decoded and looked at. And she told me something really interesting. She said the FDA is kind of like a nanny state and doesn't want people to know about lots of things because it drives them to be worried about things before maybe they should. But she said if you go to Canada or you go to the UK, you can get a lot more out of the markers that you get from the 23andMe scans than you can here. And I'm interested in how you both feel about this notion, because it seems to me that in a world in which the genetic arena is opening up so much. Isn't it better than not to have more information flowing? And today, within the United States, the FDA is preventing 23andMe from sharing some of what it gets.
Well, I can't comment directly on the 23andMe
Right.
and FDA.
But on the general.
But in general, I feel like there's like this paternalistic overtone to our entire medical system, you know, kind of in my training, you know, it's your responsibility to do the very best for the patient, and you kind of feel like you're bearing a lot of that burden.
Right.
And I think that needs to shift. You know, so now on the other side of the coin, as a parent, I say, no, I'm willing to take the risk. I know my child best. I read the papers. I understand it. Give a chance.
Right.
Give this child a chance. Give this child a chance.
Sure.
You know, I think we have to move out of that
Right.
kind of caretaker type of role.
Elsa, reactions?
I agree, and I think that there is a move, and at least at the University of Minnesota, where I used to work before I retired,
You don't seem very retired.
I'm not.
Yeah.
You know, patients were given all the information that they wanted. You know, they have access to their own medical records if they want. And I think that that's really an important thing. I think that I would like to look at my own medical records. I don't want to be in the dark. And I think a lot of people feel that way, that they would like as much information as they can get. You know, and I think that part of that is also preventative. I mean, I think that you know, if you know that you're a carrier of a disease, you are more alert to it, and I think that for example, is a good idea.
Let me ask those of you who have questions or comments in the audience, we can make them. Bring the mic right to you here. Hi, if you'll just, and good morning. I can't see you very well. I don't know if you're awake or not. Yeah.
Kevin Fowler, I just wanted to support what Dr. Neal's talking about.
Yeah.
About what's absent in development is including the patient from the beginning to the end. I'm a transplant recipient myself, and everything you're saying is dead on. So I just want to amplify what you're saying.
Can you, I couldn't hear you. Can you tell us what she's dead on about?
Just what she said is that just if you take a look at the patients and patient organizations should be involved from the beginning of concept,
Right.
collaboration at that point, all the way to post-approval, right? That the patient is viewed as a partner, right? Because what she's saying here, Dr. Neal, is what's absent is humility in the healthcare system. And that's what she's advocating, is humility. It doesn't take to be the smartest person in the world, in the room. It just takes time to listen to people. And that's what I'm hearing from you, so.
Have you seen, just real interesting, have you seen a case where that engagement, the equilibrium between, you know, patients and advocacy groups and pharmaceuticals and academics and scientists worked well?
I mean, from my experience, if you look at the ideal state, right? It's a beginning from conception
Sure.
to end. I haven't seen that. There's different intervention points along the way, but in terms of the ideal that she's talking about,
Right.
I've not seen that.
Thank you very much. Other comments, questions? Be brave or I'll pick on you. You look like you have one, I can tell. In the third row, you look, yeah, I could tell. I know you can have a comment. Let's get the microphone over to you. Yeah, I could just feel it.
Hi, I'm Alexis Bjork. I'm the mother of fraternal twins, 28 years old, that have late onset Tay-Sachs. I'm actually, I had a really interesting experience yesterday at the COPA meeting where I felt like I wasn't doing enough, and I'm here, and Dr. O'Neill said, you are doing enough because you're here.
At 6:30 a.m., no less.
Listen, I'd be here at 4 if I had to be, okay?
Next year.
But I'm also fortunate that I've been working with the NIH on a clinical trial, several actually,
Right.
and Dr. Cynthia Tift, and also Sucon, and a drug company that I can't talk about. And so I do get a sense that there is a little bit more of this collaboration with the patient going on. Now, honestly, this is all fresh and new to me because this is a 2-year diagnosis. That's how old, you know, that's when it happened. But even though I'm frustrated that a lot of conversation about Tay-Sachs doesn't take place here. None of the posters out there talk about Tay-Sachs. It's Gaucher's and Fabry's.
Right.
So that's my comment, and
So before we
keep
let
up
you
the great
go,
work.
what would you like to see shift? Not necessarily here, but in the partnerships you have. What do you think the players that you're dealing with could all
Speed.
do a little bit better?
I need speed. I need speed. The clock is ticking.
Speed.
My children's legs are getting weaker. Their speech is becoming affected. I don't want to see them in a wheelchair. I don't want them having issues swallowing or talking. That's the long-term diagnosis for them. They're both active participants in this. They
Right.
are willing to tell their story. The other thing is they're both contributing members to society. One of my daughters is a nurse, and she's actually pursuing a master's degree at Clemson University for a nurse practitioner, and my other daughter works remotely in Hilton Head for Lord & Taylor in a corporate role. So I need speed.
Thank you for sharing. Let me ask Cara and Elsa to both give us your final thoughts and reactions to what we've just heard. Cara?
Time is the most precious commodity, absolutely, in so many rare diseases. I mean, Sanfilippo, these kids really just fall off a cliff at around 4, their peak maximum development usually
Right.
on average.
30
and
months,
going from talking many times to no speech within
Right.
a very short amount of time.
Thank you. Final
I think-
thoughts, Elsa?
Yeah, so I think that there are two sides of that coin. And one is that it takes a long time to do the clinical trials that are necessary. It does take, a period of a year or 2 years to run a clinical trial, not to speak of the research that has to come before to find, the right dosing and all of that sort of thing. But so where do you speed this up? I mean, maybe it's the FDA. I mean, maybe that's one of the things that takes a long time. And, and maybe it's the prevention of certain kinds of phase 1 trials to come along, in a timely fashion, if the
Right.
FDA can get them to do it more, get a faster response. I understand the need for speed, and
Right.
I'm an advocate for, treating as quickly and as early as possible.
Well,
We saw it in the transplant population.
Let me thank you both for sharing a bit of your journeys. Thank you so much, Cara O'Neill, for the works in the Cure Sanfilippo Foundation. And Elsa, I hope you never, ever retire. Thank you very, very much.
My husband wouldn't agree.